Hi, everyone. This is Joni McGarry. Thank you so much for tuning in. If you're paying any attention to global public health these days, certainly you've gotten the message that we're in an existential crisis, that the frequency of pandemics will be picking up speed, that they're just around the corner, and that massive amounts of money and funding needs to be deployed toward building the architecture of a response to such a future event. But do you ever wonder what data they're using to support these claims? What are they looking at that could lead them to such messaging that is very, very different than it was a mere 5 years ago, pre-COVID? Our guest today, Dr. David Bell, is going to help us unpack that. Dr. Bell is a senior scholar at Brownstone Institute. He's a public health physician and biotech consultant in global health. He has extensive experience, including years as a medical officer and a scientist at the World Health Organization, and he was a program head for malaria and febrile diseases at the Foundation for Innovative New Diagnostics. Currently, he's working on a multidisciplinary team at the University of Leeds in Scotland, and they're working on a project called REPAIR, which stands for Re-Evaluating the Pandemic Preparedness and Response Agenda. Part of their mission is to analyze that very data, the same data that is being used to support the messaging of urgency and fear about future pandemics and to justify enormous expenditures. David tells us what Repair is finding, what he sees as the motives behind this agenda, and what its impact will be on very poor nations that rely on funding for traditional public health measures to prevent malaria, TB, and AIDS deaths. Part of the pleasure of doing this podcast for me is to be able to engage with really smart thinkers like Dr. Bell, who help me understand these complex situations. I'm excited to share this conversation with you, and I hope you enjoy it as much as I did. I'd like to welcome to the show Dr. David Bell. Hi, David. Thanks for joining me.
Hi, Joni. Thanks.
I was really interested in talking to you today because of your extensive experience in global health, your work in the Brownstone Institute Repair Project, and what your thoughts are in general on how public health is going globally and locally and how the future might turn out. So I'd like to ask you a little bit about your work so far in public health. Give us some background on who you are and what you've done.
Okay, yeah, I'm Australian originally, medical doctor, public health physician in Australia. And I worked in the World Health Organization for about 8-9 years, in mostly on diagnostics and malaria and infectious diseases. I worked on the first SARS outbreak, among other things. I was program head for malaria and infectious disease or febrile disease at the Foundation for Innovative New Diagnostics, which is a large sort of fund in Geneva for diagnostics in low-income countries. And I was director of health technologies at Global Good Fund, which was a Gates-run development lab near Seattle in the US. So I'm now based in Texas. I consult in biotech and global health, low-income country public health. And, as you mentioned, I'm working for the University of Leeds on the Repair project and on a number of other projects, looking particularly at, potential reform for the WHO or what we need from an international health body.
Mm-hmm. Thanks. When COVID hit, what did you make of what was happening at the time in terms of this thing happens and all of a sudden we seem to be acting in a whole new way for public health? The response was much different than anything we'd ever seen in our lifetime. And so for somebody who's had such on-the-ground insider experience, what did you make of that, and how did it change your view of public health and how you think public health might be operating as a result?
Yeah, so it didn't surprise me in the way it surprised a lot of people, in that I knew that a lot of people wanted to do what happened.
You mean the huge lockdowns and
that sort of thing, and playing up a relatively small outbreak for pharmaceutical reasons, essentially, for profit. And I'd been in meetings and discussions on pandemics for the last 10 years, 20 years, really. So this wasn't out of the blue. What surprised me was the way that so many of my colleagues and the media, etc., went along with it. I mean, in retrospect, there was a lot more groundwork than I've been aware of, or it was more effective than I expected in, the denigration of any dissent or contrary opinions from the mainstream and establishing a mainstream narrative. So that there are two schools of really public health in the from 2005, 2010 onwards. One was the traditional one, which is noting the fact that the reason we live longer in wealthy countries is better nutrition, better sanitation, better living conditions, and they're the main drivers of not dying and of having a better health, as WHO would say, physical, mental, and social well-being. And then there's another side which wanted to use pharmaceutical interventions and other interventions, particularly vaccines, much more strongly. And, these things work, but they are not the reason why in wealthy countries we live longer. They've added a bit at the end, but they're not the primary reason. This isn't controversial. This is just the way it is. It's how the government data shows this over the last 100 years. But you can't make a profit out of those things. And around the year 2000 or so, there was a big increase in the interest of private money in public health. I think partly because they could see that this was a way to make a lot more private money. And there's a huge market of billions of people. If only you can convince people that rather than just having better sanitation and better diet, they actually take stuff, get injected with stuff regularly. And you can charge for that. It's a commodity that you can make money out of. So you had these two streams of public health, even up to 2019. Late 2019, the World Health Organization's pandemic influenza recommendations say, not under any circumstances, quote unquote, essentially do lockdowns, close borders, do track and trace and establish outbreak, etc. All the things that we did in COVID, they said, do not do under any circumstances. And things like masks, they may or may not work, but they won't help much. And it didn't even envision prolonged workplace or school closures. It noted that for a short one, you may do more harm than good. They talked about, a week or two. So that was orthodox public health. That's the evidence base. It's what we know is better in the long run because health is connected to economies and to social capital or so on, how we feel about ourselves, whether we're employed or not. That all affects our health outcomes. So it recognizes that, whereas the other side was lock everyone down, develop a vaccine, mandate it or coerce it, and make a lot of money. And but it's not just about profit. It's partly about things like excitement. During the first SARS outbreak, people got excited. They public health people had been investigating, diarrhea outbreaks in the local Korean restaurant or something, and suddenly they were saving the world, and it gets to you. And so from that time, there was a big increase in the number of people who wanted to work in pandemics, and this is exciting. We're all human. It's also lucrative. So there is this sort of move in public health towards this, and it sort of suited the people who would make money out of it. It was so easy to influence the behavior of public health professionals.
Let me just ask one question. You were saying in 2019, there was the orthodoxy of public health that said under no circumstances, lockdown, et cetera, and that had been widely accepted for many years. And you said there was the other side that was for lockdowns till vaccine. But that wasn't was that talked about in
Well,
2019, or
it was
did it
talked
come
about.
on the scene later?
Um,
Or was it like a concept of how to prepare for something like
well, people
this?
know about things like Event 201, which was a meeting in
Mhm.
New York about the time that this
Started.
influenza, the influenza thing came out. And that was all about lockdowns. There was
Mhm.
meetings before that all about lockdowns. The Rockefeller Institute had put out in 2010 or 11, recommendations along those lines, etc. So Operation Lockstep, I think they called it. So there is this other side that wanted to do this, and
Mhm.
it's not new. If you go back 100 years, that was the standard. This is a sort of colonialist, neo-fascist sort of approach to public health, that you force people to do what they're told because you're the experts and you're in control. And the international public health started with it was the 1851 was the first international sanitary conference in Paris, and that was basically colonialist countries from Europe who were
Mhm.
meeting to discuss how they could stop cholera and similar diseases from coming from the colonies and coming across their borders. And it was it was a colonialist mindset even in the 1930s with the League of Nations Health Office, so mostly colonial powers. And so it was very, that had been in a way the traditional approach, that you just tell people what to do. After the Second World War and what happened under the fascists in Europe,
Mhm.
there was a movement to basic human rights and the Nuremberg codes, that they're more about research, medical research, but it's related, just emphasizing that you can't do anything. You can't inject anyone. You can't force people to do anything medically without their permission and full informed consent.
Mhm.
So really what we're seeing in COVID is a rollback to the sort of eugenics, medical fascism of earlier times.
Well, that was definitely true in our country, and it seemed to be true all around the world. And so this happens, all of the lockdowns are established. Do you think that because they were so, and I say successful in that people
Mm.
did actually lock down? I don't think they were successful in by any reasonable measure in terms of health or wealth, except for the very, very high up 1% of wealthy people. They were very successful. But do you think now, are you seeing that this has gotten a real foothold in public health, and how has it shifted the resource allocation in public health to that model versus the human rights, less colonialist model? And does that can we segue into your work at Repair? Does that dovetail with that?
No, it does. And we hear lip service to equity and human rights and um, decolonization, but the pressure is for exactly the opposite, which is a big centralization of health. And it is
Mhm.
surprising because if you go back to like Alma Ata in the late 70s, it's a declaration around primary care, etc. And this was mainstream. This was not, you know, all the stuff that human rights and community control and so on. These left wing, as they were then,
Mhm. Mhm.
mainstream left wing beliefs. They're now, we're told they're now far right conspiracy theories or something. And
Mhm.
the mainstream has moved to this very vertical approach where you strengthen the center, WHO, and that most of the reforms around WHO recommendations at the moment are pushing not what we work on, but most of them are pushing to increase the control
Mhm.
within WHO,
And
centralize it down, downplay the country offices, etc. And it's all about health security, which means you see health as a security issue, and anything is a threat, and WHO is there to stop threats, and it's more like a war footing, which is the sort of rhetoric we saw early in COVID. And rather than, what do we do to improve human resilience so that we have
Mhm.
better well-being, which we know what to do. It's just
Mhm.
not very profitable. So COVID provided a war chest of hundreds of billions of dollars in profits to the people who were pushing the lockdowns and the mass vaccination. So they have a lot more money now. And most of the pressure in international public health, most of the salaries and the movement is towards more vertical programs, centralization, and particularly around outbreaks and pandemics. And, we'll get to it with repair, that these cause a tiny, tiny fraction of the burden of disease. But they are absorbing a very large proportion now of the funding and the salaries, etc. And the other one is climate and health, which is intermingled with it. And again, climates always change, and climatic change will change health, but there are massive exaggerations on the way that a degree or so of warming of the planet will affect health. I mean, most people live in the tropics and they're fine.
Right.
Which people forget. There's an amber alert in the UK today because it's 28 degrees Celsius.
And tell me.
Well, which is, what's that? It's in the 70s, I think.
That's an alert?
It's an amber alert, yeah. And this is just quite insane. But again, I think there is a lot of money to be made in this area. And that is where the bulk of the funding is now. So it's where most people will go for salaries. And if you're running a research project, you've got a team under you, you need to fund them, or they lose their jobs, their kids go out of school, they have to move. To do that in international health, you almost always have to say climate's a terrible thing for health, climate change, and pandemics are the biggest threat that we face, are an existential threat, and therefore, etc. And then you'll get your funding. So it's like pharmaceutical companies, they're there to make a profit. They're not there for an altruistic reason. They are for-profit companies. Their only role is to make a profit. Most people, their primary interest is to get a salary and support their families. So they will go where the money is.
Well, let's talk a little bit about that to support this growth in the, what is essentially an industry. There's a lot of messaging now that is very sensational, very urgent, pandemic right around the corner, terrible threat, exponential increase in the threat of pandemics, which is the work you're doing at Repair, at the Brownstone Institute, is really to take a look at the data that these organizations are using to support that message and see if it is robust and what's really going on there. Is that a correct assessment of what it is?
Yeah.
If you could maybe just tell us what Repair stands for, how it became established, how it came to be established, what you're finding in that work, because it's really quite revealing, I think.
Yeah, so it's at the University of Leeds in the UK. Brownstone is supporting it. And that's important and Brownstone has no influence whatsoever on.
Right. I didn't mean to misspeak. Okay.
The independent University of Leeds project. But the funding is important because there is very little funding to look objectively at this area, because most funding in public health is tied to governments and to
industry. Yeah.
And this is not. So that's why it's important, but it's independent. It allows us to be independent. So, it stands for reevaluation of pandemic preparedness and response. And we've been looking systematically at the major publications, for instance, of the World Bank, the World Health Organization, G20, etc., that are pushing the pandemic agenda internationally, and particularly people know about the International Health Regulation Amendments, the Pandemic Accord, Pandemic Agreement, which has just recently passed but still being negotiated. And these are instruments that are designed to increase the centralization and control in an outbreak, and to make it faster and easier to declare an outbreak and to respond to it. And the response is essentially lockdown 100-day vaccine, mRNA-based vaccine, and then mass vaccination is the sort of model that is behind it.
Mhm.
So we've been looking at the reasons for this, and the whole thing is illogical if you stop and think about it. So infectious disease has been declining steadily, and is still declining steadily over the last 50, 100 years. The last very large outbreak was before we had antibiotics. It's the Spanish flu in 1918-19. That was before modern medicine, before any modern antibiotics at all, etc. So, and we are better fed now, as well as having better medical care. We have better sanitation, etc., etc. We have more space between us, actually, in terms of living conditions for most people on Earth.
Mhm.
So that's why infectious disease is dropping, because we're more resilient against infectious disease. That affects pandemics as well. Pandemics are just an infectious disease.
Mhm.
So logically, we'll be less affected by pandemics as time goes on. And that's what we see over the last 100 years. So there was a flu pandemics in late 50s and late 60s that killed about 1 million people, which is sort of twice what die every year of the flu. And then really nothing until COVID, which, as we know, is probably related to manipulation
Mhm.
of a virus and not a natural event. So that's the trajectory. Yet what we're being told is there's an existential risk of increased pandemics. We'll have another one in the next 20 or 30 years. That 2.5 million people die every year from respiratory virus pandemics on average, etc. And so we've been looking at how they come up with this data and these numbers. And for instance, the G20 makes a statement, the report to the Secretariat from their high-level panel, which was the basis of the G20 countries supporting the WHO pandemic agenda.
Mhm.
This has a couple of bits of information to back its statement that there's an existential risk of pandemics. So one of them is major outbreaks over the last 20 years, 2000 to 2020. It was published in 2022. And it just has a list of years and a list of diseases. If
Mhm.
you add up the actual mortality from the diseases that they list, it comes to about 180,000 deaths over 20 years. And 155,000 of them are from the swine flu in 2009, H1N1.
So
So
that's what they're calling the existential threat, the
yeah,
increase.
this is major outbreaks over 20 years. And the swine flu, which is most of them, killed less than normal flu. And then the next one is Ebola outbreak in West Africa, which is geographically confined. And then an outbreak of cholera, which the UN caused by bad sanitation from their compound in Haiti. And that's virtually all of the deaths that they could find in 20 years to support this statement. So, and we see that repeatedly. They take into, there are graphs of increases in recorded outbreaks, but they don't take into account the fact that in 1960, we had no PCR, no point of care antigen tests or serology tests, no gene sequencing, etc. We've invented all these ways of detecting outbreaks. So now, although infectious disease is going down, we're much better at distinguishing a little outbreak of a pathogen from the background of infectious disease. So we can say, there were 20 the last year or something. In 1960, that 20 would have been there as well.
Mhm.
We couldn't detect them because we
Sure.
didn't have the technology.
Well,
And
that also brings up the question of, we're defining now cases as a positive PCR test. And
yeah,
so it's even if the numbers are large, it could be very meaningless if no one's really
so
sick.
it is meaningless, and every medical student is taught it's meaningless. WHO put out a missive in 2020 noting that it was meaningless, that you could not say someone's got a disease just on a PCR, but you need clinical data as well. This is just standard. This was the interesting thing, and this is why I was surprised that it works so well, because these are just basic things. It's not, you don't argue about, is PCR alone good enough to diagnose a disease?
Right.
It's not. A disease is the body's reaction
Sure.
to a pathogen. So you can do a PCR, you can find group A strep in your throat. Doesn't mean you've got a group A strep sore throat.
Mm-hmm.
It means you've got colonization from the bacteria and it may be doing you no harm at all.
Mm-hmm.
So with something like a PCR test, you have to first understand the false positive rate, how many cycles, etc., and which gives you an idea of how many of that organism are there. And the fact that even when the organism's gone, genome can hang around. But you also have to understand that just detecting a genome or an organism doesn't mean you have a disease.
Mm-hmm.
That is a sickness. It means that your body, you have a fever, you have headache or whatever.
You have symptoms.
Symptoms. And
Yeah.
this is so basic. Like anyone in the street understands this. Yet we managed for about 2 or 3 years to pretend this wasn't true.
Right, right.
Like we pretended that, and we had people like WHO saying that immunity is somehow different from a vaccine than from post-infection immunity, and vaccines much more effective. We all know it isn't. We all
Right.
know that in general, post-infection immunity is better because you have the whole organism
Mm-hmm.
in the right place, in your throat, for instance, rather than injection of a single protein, which doesn't even affect, your first line of defense for a respiratory virus, which is the immunoglobulin A release in the lining of your throat. So this is just standard. It's before 101. I mean, you learn in high school or primary school, but we managed to do away with all this knowledge somehow.
Yeah, it was really remarkable. But you were saying, so you're going through the numbers and you're finding that this existential threat, the statements that the G20 is making about this terrible threat of pandemics, when you look into their data, it doesn't hold. It
It
doesn't
doesn't
really
support
support
it at
it.
all. No, it doesn't support it at all. And WHO is the same. They have, in 2023, they put out future surveillance and managing epidemics and pandemics, two key publications pushing this agenda and this is for countries and so on to go by. And that they have in both just a single graphic to back this whole premise. And it goes from the year 2000 to 2020 or so. And it has diseases occurring and then continuing, like cholera and plague and yellow fever and influenza. And there's nothing in 2000. And suddenly you've got about 8 diseases going on in 2020 and some others that started and finished. And this is it. And you look at this and you think, oh, things are getting much worse. But all these diseases I just mentioned, they're all declining. They were much worse in 2020. They were way, way worse in 1950 or in 1900. So all these diseases are going down. And it's just, this is the classic example of misinformation in the WHO's own parlance.
So just let me clarify and confirm that you are using the same data that they're
Yes,
looking at. You're
and the
taking
same citations.
right, and so you're not like doing different research. You're using their data and
Yeah.
citations, and you're actually looking at the citations, reading the papers, and you're realizing that the statements are not being supported by that data.
Yeah, they are
What
misrepresenting their own data.
and what do you make of that? How does something like that happen? Um, and why isn't there a check on that so that they can get it right?
Well,
Because they're talking about wanting $31 billion, is my
yeah,
understanding.
31 billion a year. Whereas the total WHO budget at the moment is about 3.5 billion. So it gives some
Well,
context. And
yeah.
we spend about 3.5 billion on malaria, which kills over 500,000 children, something similar on tuberculosis, which kills 1.3 million people a year. So versus, 25,000 or so on average for these for natural outbreaks.
Mhm.
So yeah, it tells you that this isn't primarily about public health, which we know because then you'd be concentrating on nutrition and sanitation, living conditions. It's not about truth. obviously. That's not the priority here. So they talk about misinformation, but this is exactly what they're talking about. What they're doing is exactly their definition of misinformation.
Hmm.
Information. But if you look at what's happened over the last 20 years, 25 years since 2000, when I mentioned there was this interest. So we have these product development or public-private partnerships, which are concentrated on product development, etc., like Gavi for vaccines,
Hmm.
CEPI now for vaccines for pandemics, Unitaid, etc. And they grew up alongside WHO, which used to be virtually the only one in this international health area. And they they have industry on their boards, they have private influence on their boards, and they're all about getting commodities out that can be sold for a profit. It
Which is
doesn't mean,
was it also a top-down approach instead of
yes,
building
and
capacity on the
of
ground?
course, some commodities are good. We need them in
Sure.
health. But you don't want the people who are making them on board of the organizations that are
I know that
deciding how
seems
to. I
so
mean, it's just so obvious. Yeah.
right. It seems so basic.
Yes. But so WHO is working within this context, trying to keep up. But also WHO's funding has changed over that period. So now it's about 25% private sector funded, and it's about 80% specified funding. So originally WHO, it got funding assessed from countries based on their GDP and their population, and they used that to do what was best for public health, and they concentrated on malaria, TB, sanitation. Yeah, smallpox was a big thing then.
So that
Um,
was like a general fund. They were funded by countries, and then they could
mm,
deploy those funds where public health funds were really needed. Is that
exactly. Based on
okay?
on need, on expertise, on where they thought would make the biggest difference, and what countries asked for them. So it's run by the World Health Assembly.
Hmm.
So now 80% is specified funding,
And tell me what that
right?
means.
80%. So that means that the funder gives some money for WHO to do a specific thing. And it can be very specific. They can, the funder can say you should employ these people, you do this work, you have these meetings here, you work in these countries for this particular project.
Okay.
So they can give money for malaria vaccination or for um, tuberculosis treatment or for outbreaks. And so WHO, most of its work now, about 75, 80%, is not, it can't even do what it thinks is most important. It has to do what the funder told it. So it has become an agent of the funders.
And the funders in this case are private.
They're private and they're countries. So most of it
Okay.
is 25% private, 75% public.
Okay.
And that's dominated by, up to a year ago, the US,
Hmm.
Germany, Great Britain. So the countries with very large pharmaceutical industries. I mean, Germany put lots of public money into BioNTech,
Hmm.
which produced the Pfizer vaccines and is producing other mRNA vaccines. It runs the new biohub for WHO, which is intended in Berlin to get all this information that countries are now required to produce through the International Health Regulation Amendments on potential outbreaks or new variants of viruses.
So it's
Will
it's
go to
part of
Germany, and they will use that to prioritize vaccines, which they will then sell for
so
lots
it's
of
like a
money.
surveillance for data that's being fed into Germany for this. Is that
Yes,
what? Okay, go on.
yeah. So they have very large. These countries also have very large vested interests in their industry.
Hmm.
So WHO, there's not much money in improving toilets. There's not much money in micronutrient supplementation, even though we know that that is probably the best way of stopping children from dying. And if you vaccinate a child against measles and they die of malaria next year, that is counted as a life saved, but it's not.
Wow. No,
It's,
it's negligent.
well, yeah, it's not dealing with the root cause,
Right.
which is not a lack of the measles vaccination. The primary root cause is micronutrient deficiency. That's the primary reason why you die of the measles virus.
Hmm.
So yes, a vaccination will help. A vaccination will stop you from being infected or passing on. But most measles vaccine, as an example, went away. 95 to 98% went away in wealthy countries before mass vaccination because of probably particularly vitamin A, but other
Hmm.
micronutrient
Hmm.
supplementation and improvement in general diet.
So you have these countries now giving money that's specified funding. Is that the understanding of it?
Most of it,
Because
yes.
most of it,
Yeah.
and you think perhaps it's in service of the industries in those countries that
Well, of
are,
course. I mean,
yeah,
that's what a government is there for. This is a problem that this is a difficulty. The UK government will work to the UK's interests primarily.
of course.
And they're sort of elected for that.
Hmm.
Um,
Well, and people are
so,
elected based on a war chest of money, often from these kinds of interests. So
well,
it's
of course, yeah. And so, yeah, the politicians are heavily supported in a lot of countries by pharma. A pharmaceutical company, yeah, the role of Albert Bourla, the CEO of Pfizer, his
mhm,
role is to maximize return on investment for his shareholders.
right,
It's not to help some child in Burkina Faso or Utah or whatever. It's to maximize return on
sure,
investment. So the best way to do that is to have a very cheap vaccine to make, minimize the testing, get it through regulatory approval with as little effort and money as
hmm,
possible, and then get a government to mandate it.
hmm.
And then, I mean, it's the dream from a commercial point of view to be able to do that. And that's
Well,
what pharmaceutical companies can do. And then you're protected from liability for a lot of it.
because it's an emergency or it's on
It's
the
an
childhood
emergency
schedule.
or it's
Yeah,
on the schedule.
right,
So you cannot fail to make a healthy profit that way
sure.
and with almost no risk.
And
So
so,
that's his job. So he will manipulate the media because that's his job, or his company will. They'll manipulate politicians. They'll do all these things because that is their job in a sort of amoral capitalist society, is to do everything you can to get return on investment for your investors and to maximize the profits of your company.
and I think that people, well, they used to think this way, but they think that because it's a healthcare company or a company that is in the health arena, that somehow they do have
Yeah,
a more of a moral operating system. But I
because they pay advertisers to convince us of
sure,
that, because that's what they have to do.
right,
And the largest fine for fraud in history was paid by Pfizer. I mean,
hmm,
that's not surprising because they're a big company, they make lots of profit. This is a business risk, it's a business expense,
right.
basically.
It's
You know,
calculated into your costs. It's
yes, I
calculated
mean,
into your product safety.
yeah, the Vioxx scandal with Merck is well known. Tens of thousands of people died from a side effect that they knew would happen, but
Right.
was not told to the people taking the drug. So, um, the, yeah, the, because their role is not to tell those people that they might have some cardiac side effects. Their role is to maximize profit.
Right. Right.
If they're really worried that there'd be massive lawsuits, then they go and tell those people. But if they're not
Or
too
they'd
worried
pull the
about that,
or they'd
then
pull
they
the
can,
product. Yeah.
yeah. But if they calculate that the profits they'll get will far outweigh any lawsuit,
Mhm.
then their interest financially is to go ahead with the
Right.
product.
So now we're in a situation now where the World Health Organization has gone from general funding to specific funding.
Mm,
And
University, yeah.
and then there's also this movement afoot to scare us all to death all the time about these pandemics to gin up the funding, which is what you're seeing with repair. How do you think, what can people do? What can you do? What will the work from repair be able to do to pump the brakes on this kind of thing? Do you think there's any hope that we'll return to a more sane and right and effective application of public health? Like, for instance, you've talked about the collateral damage, the opportunity cost of the children dying every year of preventable diseases, tuberculosis, of malaria, and now that the focus is going to be on these potential pandemics, those countries which don't seem to have capacity on the ground will really suffer.
Yeah, they will. We've already seen a drop in nutrition funding internationally.
Yeah. So, what can be done to stop this train? Do you think anything can? I mean, when you talk about during the pandemic, like our memories were erased. All of a sudden, there was no such thing as natural immunity. If somebody tested positive, they had disease. That was an incredible psyop. So we've got a lot of
Yeah.
forces being brought to bear, and people believe that we're all in this state of danger. What can be done? That's a
Yeah,
big question.
no, it is, and it's difficult because the media is, the main shareholders in the media, and much of the media are the same main shareholders in Pfizer, GSK, and so on. I mean, it's just
Hmm.
what it is. It's BlackRock and Vanguard, big financial houses. So if you go back behind Pfizer, there's a financial institution that is their main shareholders that is using Pfizer, using their other assets to maximize their return on investment. So we're up against this, and society has got to the point where inequality is so much that we have these people who have, and companies that have more wealth than most countries, and so it is very difficult to overcome that because they can buy governments, and
And
they
they
can
do. And they
buy
do.
they do, and they can buy international organizations. So I think the US dropping out of the World Health Organization has been a very good thing. Argentina as well. I think we need international health organizations, but we need one that works and that is there for the interests of the people when the people ask it. So when governments ask it, more like the original intent from most people with WHO. And people say there's certain people involved early on in WHO that had sort of these fascist intents, and that may be true, but overall for the first 30 or 40 years of WHO, it was almost certainly a force for good, I think.
Hmm.
Um, you
Let
know,
me just stop you for a second. You said that you feel like the U.S. pulling out of WHO and also Argentina is a good thing. That seems to contradict the notion that we need more funding for the old kind of guard at WHO. Like, how do you square
I
that?
don't
Like,
know if
what?
we need more funding. We need to do
Okay.
things differently.
Okay. So, do
Um,
you think us pulling out will maybe force that agenda a little bit?
I hope that it will
Okay.
help to push that agenda. I mean, the current WHO, with a huge influence of private sector and of industry, is clearly massively conflicted and
Hmm.
unable to perform its basic role. I mean, that's clear. Yeah.
Yes.
Um, so it either needs replacing or it needs massive reforms. We don't need much in Geneva. It probably shouldn't even be in health emergencies. These are national issues that nation states are best managing. Whereas, having somewhere where you can collate data, you can meet and have some normative standards around things like tuberculosis, malaria, where countries can get assistance where they ask for it for a limited period of time. WHO should be, for most of its role, should be downsizing and working towards redundancy because it should be building capacity in countries to do
Exactly.
what
Yeah.
to do this. And that was sort of the original thought of a lot of people. Now WHO is all about getting more money and more centralization to run the world's health. But that is not, we know that like health is very heterogeneous. Like the priorities of people in Burkina Faso or in Maine or New Mexico or in Germany or in Vietnam are highly different.
Sure.
And their interests are different and their culture is different, their priorities are different. So having a small central organization, but a stronger periphery where, it's run by countries and they can access these resources for their local good and their
Hmm.
local priorities. But to a point where, in order to build capacity, that they don't need outside help. That is in the interests of both these countries and of the main donor countries. It's not in the interest of people who want to make a lot of money quickly by selling stuff to people who don't need it. But So the first thing is to exclude those people from the process. And so I think, the US dropping out has at least it'll help to get people thinking. But, in the meantime, you've got the EU sort of enmeshing itself more and more with WHO, with vaccine passports and all these quite stupid things, as if pathogens stop at a border. And so if you have a passport, it's going to stop that pathogen. But, the COVID passports were completely idiotic. You had to get a vaccination to go from one country to another. The virus was always in both.
Right, and the vaccine didn't prevent transmission or infection, so
No,
I don't think that agenda was really about stopping a virus.
well, of course not. It was
Yes.
about getting people thinking along these lines and about selling the vaccine.
Right.
And it worked very well. And the problem is that, logic doesn't seem to work very well anymore. And that agenda is still there for future vaccines. So it's going to be very difficult to stop this. I think it helps if people see that this isn't completely new. The idea of feudalism, of a small, I hate the term elite, but a small, very rich class using its resources to further enrich itself at the expense of the rest of the population, is a normal state of human society for most of history. And we had a sort of 1940s to 1990s period, perhaps, where that was more or less a bit watered down, and we kept a lid on it. And then we forgot about conflicts of interest. We forgot about human greed, and we let this inequality and so on come back, and conflict of interest, and we are where we are. So it helps to realize that you can get out of it, because we've got out of it before.
Mhm. Are you hopeful that, tell me a little bit more about what you're hoping will be a final product from the repair project, and are you hopeful that that will be useful in educating, policymakers and the population in general, that the messaging coming out of these organizations is not, um, based on robust data?
What's I mean, the product is the truth. So we're not giving opinions. We're laying out the data and the citations and saying this is what they actually show. And no one has refuted the reports that we put out so far. And we're looking a bit more now at, trying to look at what is driving this and why there is this disconnect between what's actually happening and what these institutions are saying, which I hope will be helpful. It is difficult because the media and so on, by and large, don't want to know the truth. They want an exciting story about how we're
Sure.
going to die next week from the next outbreak.
It sells a lot of papers and gets a lot of clicks.
It does, and
Yeah.
it also I mean, it is not in the interests of the main advertisers in mainstream media to have the general public realizing that they've been misled
Sure.
for the last several years, and that actually they don't need to be investing their taxes in these companies. The basis of this is not private companies just investing their own money for profit. The idea of the public-private partnerships like Gavi and SEPI is to channel public money, taxpayer money, into these private companies for their profit.
Right.
So it's a business model that is the dream of these companies, and it's very much in their interests to keep it that way, and they sponsor the media to keep it that way. So it's very difficult to get the truth out. But my hope is that, as I said, no one has refuted these reports, and we know they have had some influence on the agenda, because the country delegates and so on at WHO, they're aware of this. And I think a lot of people, and perhaps an increasing number in public health, are being able to recognize the truth and admit it. It's very difficult for the last few years, even if they knew it. I think with the change of government in the US, it has become more acceptable to, um, to say, maybe we don't need to vaccinate people who are already immune to a disease, and
Mhm.
with a vaccine that won't stop them getting infected and won't stop them transmitting. But they already have slightly better immunity than the vaccine can ever give them, and
Mhm.
he's actually shown this. So, we don't need to keep boosting them.
Mhm. Imagine that being even a controversial statement, but
Imagine that being a
yeah.
controversial statement, but we've got to a point now where we can actually state the truth. It's like the Spanish Inquisition sort of being rolled back a bit, and actually say, well, maybe the Earth does rotate around the sun sometimes.
And not being, ostracized from society for saying so,
Yeah.
which, I and many people I know were just from, challenging the narrative that didn't make any sense, at the time and continues not to make sense. So, yeah, I think, um, I wanna pivot a little bit, on that note about the pandemic industry, unless there's something you would like to add about what you're seeing and what your predictions are for that. I was gonna pivot to your, article very briefly on the AAP.
Yeah, I don't know what will happen. The pressure is very much still for a future of more fear mongering, more lockdowns. It will be definitely a net negative on public health overall to impoverish more people. Um, and the remarkable thing about COVID, the COVID outbreak, is that in every past outbreak like this, excuse me, acute outbreak, um, you've had 1 to 2 years of an outbreak, and then mortality's gone back to normal or even below normal because
Mhm,
the very sick people were killed by the virus, and then so you have less mortality for a couple of years.
mhm.
In COVID, excess mortality has kept rising now for 4 or 5 years, and is still above what we'd expect. And there is, I think, it's multifactorial. I think the mRNA vaccines may well have something to do with it. Even in the Pfizer 6-month trial, there's more mortality in the vaccinated group than the unvaccinated group, and that's published in the New England Journal of Medicine. It's not a surprise. Um,
It's astounding.
yeah, most people don't know it, but
No, they don't know it.
West 4 in the supplementary data. Um, and sorry, I've lost my thread,
Yeah.
Jane.
Well, I just wanna jump in on that when you say, the excess mortality has continued to rise even after what
Yes,
it
yeah,
should have peaked and gone back down, and so
it
you're
should,
suggesting
and
that we
yeah,
don't know why, and
we don't know why. I mean, the lockdowns would have done the same. Impoverishing people increases mortality. We know this. Pushing people more into drugs and alcohol
mhm,
increases mortality. Um,
but there
yeah,
was also that huge
thinking,
intervention of the
yeah,
vaccine, so
vaccine.
but
So
nobody seems to be asking that question at any
no,
scale,
and it's
which
a
is too
difficult one.
bad.
I mean, Sweden, almost everyone took the vaccine, but they have much less excess mortality than others. But we also know that there's a lot-to-lot variation in side
Right.
effects from the vaccine. We don't know why. Maybe some batches had much less mRNA, some batches might have had almost none. And
Well,
if
because when you
I
say
was Pfizer, I would give the batches that I knew would have the least side effects to the countries that will do the most monitoring, and I give the batches that were poorer quality to other countries, like through COVAX to Africa and Asia and so on, where I think the monitoring won't be as intense. So that may be what's happened. So I think, from country to country, we're seeing quite a variation, and that may reflect the variation in lockdowns. It may reflect the variation in vaccine quality and a
mhm.
lot of other things.
Yes, because they scaled, I mean, there had to be a variation in vaccine lot quality because you cannot scale a product that quickly, that big, and expect to have a consistent manufacturing process.
No, you can't.
It
And
just doesn't happen no matter what the process is.
yeah, there's a good study out of Scandinavia. I think it's Denmark, but one of the Scandinavian countries that shows this. They look at the adverse event profile of different lots, and there's a huge difference
Mhm.
from one to another.
I think there's still so many questions to answer on the COVID pandemic. It's a bigger topic than I can
Yes.
certainly get into today. Um, if you don't mind, I wanted to pivot just very briefly to your recent article on the American Academy of Pediatrics. And like many other people, whenever I see, or it used to be, whenever I would see like the American Academy of Pediatrics, I would think of a benevolent group of pediatricians who care about um, child welfare and health. And so the recommendations would be something that any responsible parent would want to take into consideration. But your article really points out that they are really much more of a trade organization than a group concerned with public health. And if you would just want to tell us a little bit about that article and particularly about their top 10 priorities and what is missing from them, just to sort of bring
Yeah.
people along on how to look at such an organization.
Yeah. And they represent, I think, 67,000 or something pediatricians in North America. So they had the top 10 priorities, and yeah, nowhere in those priorities um, does it mention childhood obesity, which, 30-40% of children are obese, and it's getting much worse.
Hmm.
It has been for the last few decades. And we know that this will lead to diabetes and strokes and renal failure and cardiac disease when they're adults. So this is a health disaster, and it's
Hmm.
not mentioned. Diet's not mentioned. Autism, CDC says, is for 1 in 38 Americans, much more even in California, particularly among boys. It's not mentioned, but there is a mention of more access to treatment
Hmm.
for neuro
Divergent people. Yeah.
neurodevelopmental disorders.
Okay.
And yeah, so it goes on. And their first priority is to do away with all exemptions, non-medical exemptions for a vaccine. So the first priority of these people, and the organization, importantly, is sponsored by a number of drug companies, pharmaceutical, including, GSK, Sanofi, I think, Eli Lilly, Moderna.
Hmm.
Um, so they get a lot of money from these. So their main priority is to stop parents from having any way of um, refusing vaccination for their children. And for that to be the main priority of an organization is staggering. And what are the causes of autism? What are the causes of increasing other neurodevelopmental disorders, which they mention, but they don't mention finding out why this is getting much worse. They just talk about more treatment, which is
Hmm.
more money for them.
Hmm.
Um, so it is just a staggering disconnect from what you would expect from an organization who were, they're faced with this rapidly deteriorating health in children in North America. And none of their top 10 priorities are finding out why. And, it may be vaccine, it may be obesity, it may be toxins in the environment, etc. It's probably a combination of different things in different kids. There is
Hmm.
no interest among these priorities in finding out,
Well, there's
only
also no.
in enforcing compliance with the vaccine mandate. It's just, it's really interesting because it's so far from where I think most parents are now.
Hmm.
And it is, it is medical fascism. There is, a measles vaccine is very good at stopping measles. If another kid is not vaccinated against measles, and yours is, your kid is not at risk from the unvaccinated kid. So, of
It should be a choice then.
course, it should be a choice.
Right.
I actually think even if the choice goes much further, I think it's not just a public safety thing. I think the primary thing that a human should do, and that a doctor should do, and this comes back to Hippocrates and so on, is do no harm.
Hmm.
And if you look at post-World War II, post-fascism, we thought norms and standards, it is the patient, or in this case their parent, has the choice, the ultimate choice. Bodily autonomy is a thing.
Hmm.
Yeah. So the Academy of Pediatricians thinks that bodily autonomy should not be a thing anymore, and that the doctor should decide what goes into your body, and the parents, in this case of children, should have no role in that whatsoever. And this is number one priority,
Hmm.
this organisation for the coming year.
It's remarkably brazen, and I think that it's an example of how funding can blunt
Mm.
your create your curiosity about maybe what the data really says and about what the
It
ethics
is.
to be.
And I suspect that a lot or most of the 67,000 members don't know what the data says.
No, I would agree with
I
you.
expect that most of them are unaware of what I was taught in medical school and shown the graphs, which is
Mhm.
that most mortality from measles and pertussis and so on went away before mass vaccination.
Mhm.
And measles vaccine might have helped a few percent more reduction in measles, but there's only a few percent left. The other 97% had already gone.
Mhm.
And this was mainstream medicine. I mean, it's the truth. You can't get around it. It's the US government data, the UK government data, Australian government data. It's what it is. I've shown these graphs to medical students now who've just been absolutely shocked because they'd never seen anything like it. They'd never heard anything about this. But
Because
this is
that
mainstream medicine a few years ago. This is the
Mhm.
truth. And I think most pediatricians they don't even go there in their training. And
Mhm.
they're
Mhm.
just told vaccine safe and effective, which is just silly.
And they save millions of lives every year,
Yeah,
and
which
um
is, you can demonstrate is almost certainly not true. They
Mhm.
save some, and we don't know, that in a place where you have good nutrition and good healthy children, which unfortunately it's not so much North America now, but,
Right, right.
um, you know, we don't know, um, whether you're better off with the measles vaccine or not. We haven't got that data. We
Mhm.
haven't got those studies,
Mhm.
and they're hard studies to do, but without them, you can't say, it's definitely you're better off having it.
Mhm.
We give hepatitis B vaccine to on
Newborns.
day one to newborns.
Yeah.
That's based on two trials. One had about 250 with no control group. The other one was about 300. The follow-up was about 5 days. That's it. That's it for newborns. And if you're born to hepatitis B negative parents in North America, until you're sexually active or shooting up drugs, which most 3-year-olds are not, you're it's
You're not
infinitesimally
yeah.
small chance of you picking up hepatitis B. So there's absolutely no reason for it's almost certainly it's not a net benefit
Mhm.
in North America. It might be in, I don't know, the Pacific Islands or somewhere where they think a lot of children, there's a lot of Hep B and hepatitis B, and a lot of
Mhm.
children may get it in the playground from running
Mhm.
around bare feet and standing on the same sharp object. But in North America, that's not the case. And it's extremely rare in children. So, um, whereas we don't know what the side effects from the vaccine in a newborn are because
Mhm.
we never did those studies. We stopped at 5 days.
Mhm. Well, there wouldn't be any, incentive to do those studies. I
No,
think
there's a disincentive
yes, of
because
course.
if you inject anything except normal saline or water, if you inject anything into someone, they'll at least have a local reaction
Sure.
sometimes and a bit of pain versus nothing with normal saline.
Mhm.
So that is why they don't do, it's a disincentive for any company to do a true placebo controlled trial unless they're told to. And unfortunately, our regulatory agencies, the FDA, etc., don't tell them to, don't insist.
Right. And so you can't really get a clear safety signal because
Yeah.
the safety in the placebo group, it's not really a placebo group. So,
No, because in most of these vaccine trials, they've either injected another vaccine versus a
mhm,
new one, or
right.
they've injected all the adjuvants and everything else in the vial
Mhm,
versus all the adjuvants and everything else plus an antigen, which is probably not what does most of the harm.
right.
So, yeah, we have no data, and it's
Mhm,
not, again, it's not some weird conspiracy thing. It's the truth
mhm.
for every vaccine on the childhood schedule in North America. And it's something that probably most of these 67,000 pediatricians aren't actually aware of.
I would agree with that. I think that they are not aware. Most of the public is not aware, but an increasing number of the public appears to be coming
Yeah.
aware or starting to ask questions, which
Mm.
I think is really just going to be the beacon of hope here for larger institutional change over time because
Yeah.
more as more people question, as more people like we are talk, like we talk about it, maybe somebody will be more curious now and will answer, will ask a question about it. um, we're heading up onto our time, and a couple of things I'm going to put in all the show notes, your articles, and I'll, ask you to tell us where we can find you. But before that, I always like to ask people, given the chaos that we've all just lived through and how everything has changed, what are the things you do to live a good life in this chaos? And it doesn't have to be, I mean, like, how do you stay sane and grounded in this, increasingly disturbing, uh, craziness that's all around us?
Yeah. I mean, I live in a small town in Texas where people aren't much invested in all this. And I mean, unfortunately, a lot of people are very invested in taking the kid to the pediatrician for a wellness check and getting them injected with various things and so on. But they're not. There's a sort of a tendency not to obey everything the government says, which I think is refreshing.
Yes.
And we have and we're very fortunate in that we have a few acres, so we run chickens and ducks and geese and sheep and so on, and we can
Mhm,
have our own food from that. Um, so we sort of know what we're eating, and it's also interesting to get away from all this and just deal with animals and plants and
mhm, and do real things in the world.
do real things in the world. Yeah,
Yeah.
build a fence or something useful.
Yes. Yes, yes.
Um, so yeah, there's that. Um, but yeah, I think yeah, it sounds like a cliche, but you invest in relationships and so on. And what disturbs me at the moment is this whole stuff that's going on X, Twitter, etc. About Grok and AI, and
Mm,
isn't it wonderful that you can now get a false image of someone doing something that doesn't exist? There's more in real life than I think you can get out of Grok or Chat GPT. So yeah, I think just sort of investing in people and relationships and talking is more valuable.
I agree completely. So thank you for that. Do you wanna tell us where we can find you, or do you wanna leave it to me to put it in the show notes? Do you have a
Well, yeah, I publish on mostly on Brownstone Institute, and yeah, I'm I am on Twitter or X,
Mhm.
Bill00David, but I'm not a great social media poster.
Which is probably why you have a better quality of life than those who are. Twitter is just, anyway, I
Yeah,
don't even
it can
wanna
be
get
quite
into.
unpleasant sometimes. Yeah,
Yes, yes, yes. Well, thank you, David, for, this enlightening talk and for, just illuminating what happens in public health and what's afoot. I'll put everything in the show notes for repair, and, if you ever wanna come back and talk again, I would love that.
no, thanks, Jen.
All right, thanks. Bye-bye.